These should be matters of serious concern and reporting on beats from politics to food to transportation to social services to economics and government. We can do better as journalists in tapping hard data, rigorous research, and welcoming experts to show how good health can be made a fundamental for all. Because, as Reverend Martin Luther King observed in 1966, of all the forms of inequity, injustice in health is the most shocking and inhuman.
In case you missed the calamities of recent years, our health and healthcare have become national obsessions for many reasons. Our country spends more than any other country on the planet on healthcare. And we get some of the poorest outcomes among our industrialized peers for the trillions of dollars we expend annually. Voters also tell pollsters that healthcare is always one of their top issues of concern. And it's also become one of the most polarizing issues around. The coronavirus pandemic laid bare longstanding problems in our health and healthcare, and chief among those were disparities or inequities, now plainer to see and impossible to ignore as preventable wrongs.
Before we dive into today's session, a few housekeeping issues. Please ask tons of questions, and you can do so by using the chat function in Zoom. Our kind volunteers will be working behind the scenes to assist you in getting answers to your queries. And then we'll be back at the end of our program to preview some of the other AAJA and CCNMA events and good stuff coming up. But now we'd like to introduce you to our terrific moderators for today's program. Usha Lee McFarlane is a national science correspondent for STAT. She has reported for the Los Angeles Times, Boston Globe, Knight Ridder, Washington Bureau, and the San Antonio Light. She was recently honored by the Association of Healthcare Journalists for her beat coverage for STAT about health inequities. And her work on the disease state of the world's oceans earned the 2007 Pulitzer Prize for Explanatory Journalism. Jacqueline Garcia is a Los Angeles-based journalist with more than a decade of experience covering a myriad of issues ranging from immigration and politics to health and education. A vast majority of her reporting has focused on issues that affect the Latino population. Jacqueline is a reporter for La Opinión. She has also reported for Hispanic Linked News Service in Washington, D.C., Noticias 62, and Eastern Group Publications in Los Angeles. Garcia is originally from Puebla, Mexico, and until 2017, when she gained legal residency, she was one of more than 750,000 undocumented immigrants with deferred action, or DACA.
Before we move on, I want to take a minute to thank the California Endowment for their support of this program. I also want to thank Craig Matsuda, a longtime AAJA leader and a former editor on the foreign and calendar desks at the LA Times, who put his usual thoughtfulness into preparing the slides, the script, and other materials for this event. I also want to thank AAJA and CCNMA chapter board members, including AAJA VP of Special Projects and LA Times reporter Teresa Watanabe, for her leadership of the chapter for so many years, and her energetic work on meaningful projects like this. A big thanks also goes to our group's board members who worked on this event. Usha and Jacqueline, please take it away and introduce our wonderful panelists. Their bios have been circulated earlier. We can't thank them enough for enlightening us today.
Thanks so much, Lori and Julie, and welcome everyone. So for so many of us, it really became clear during the coronavirus pandemic that our nation is just riven with health disparities, that how healthy you are, how long you live, and whether or not you survive an infection from a frightening and novel virus is tied very, very closely to the population you're from and many of the socioeconomic factors related to that. Today, I'm so thrilled to present these top experts in the field of health disparities to discuss how widespread these problems are, what are some of the causes underlying them, and the many stories that can and need to be told about these issues. And I'll let my co-moderator now introduce the panel. Thanks for coming.
Excellent. Good morning, everyone, and thank you so much for being here. And as it was mentioned before, all of you have the biographies from our panelists, but I'm just going to give a brief introduction because otherwise we wouldn't finish on time. So Dr. Jane Delgado is the President and Chief Executive Officer of the National Alliance for Hispanic Health, the AAJA-LA Alliance. And in 2017, she was Latino leaders named Dr. Delgado, the 101 most influential Latinos in the US. Then we have Dr. Vickie Mays, who's a professor on the Department of Psychology of College of Letters and Science. And she's also the director of the UCLA Center on Research, Education, Training, and Strategic Communication on Minority Health Disparities. And then we have Dr. Nines Ponce, who's a professor at the UCLA Fielding School of Public Health and director of the UCLA Center of Health Policy Research. And she leads the California Health Interview Survey, the nation's largest state health survey, recognized as a national model for data collection on race, ethnicity, sexual orientation, and gender identity in immigrant health. And to start, we're gonna hear from Dr. May's presentation.
I'll start with, let me get to the beginning of it. Share my screen. First of all, I want to say thank you for having me. It's actually an honor to be here. Many of you, or some of you, I know, and you are more influential in science than I am in the sense of what you do with what we give you. So my job this morning is actually to start by kind of laying a foundation or kind of thinking about how do we talk about health inequities. And these slides will be available for you, so I'm not covering everything on them, but I put a slide deck together that you can have. So this is, you can have it for reference. So one of the things that, we want to start thinking about when we talk about these inequities is that there's a difference between how we think about them and the way in which sometimes we talk about them. A health disparity just means there's a difference. So sometimes when you say that there is a disparity, that's good. You make more money than your son. Well, it's a difference, but it's a difference that has reasons that are, adequate and okay. When we start talking about inequities and disparities and inequalities are exactly the same. When we start talking about health inequities, this is where we start talking about something as unfair, unjust. It has a lot to do with the ways in which resources are distributed. And when we talk about health equity, that's where we want to land. So often when people are writing things, I really push them to say, okay, let's get to the equity part, because the issue of the documentation of what is wrong, we know. But what we want to figure out is what are people's thoughts about what would make it right? Let us learn where they want to go. And then it's kind of this final thing, which I will talk a bit more about, which is the social determinants of health. And there we talk about what are the resources that are distributed either effectively or ineffectively in this country that causes a person to end up with these inequities. I love using this because it helps people to see. So the reality is there are a lot of people who have a lot, and there's some people who have less than nothing almost. When we're talking about equality, we don't want everybody to get the same thing. It's a mistake to fight for the same. When we're talking about equity, what you start talking about is making sure that each group gets what it needs. But when you're talking about social justice, we start talking about removing the barrier altogether so that no one needs to be dependent upon others, the federal government, welfare systems, or anything, but that justice is that you're going to be, which you see in the last one, participating like everyone else. That's the kind of inclusion thing. So let me kind of move on and talk about what are social vulnerabilities. The reason you're hearing a lot about social vulnerabilities now is because it's come up in the context of COVID. but it's not a new topic. I mean, I just showed you this to just let you know that the UN has been working on this for many years. It comes out of the disaster world. So when we're talking about a social vulnerability, what we're trying to say is what might harm this person. So in COVID, what we were trying to understand is what are the things that make some people more vulnerable to getting infected by COVID? And what we want to do, particularly in a disaster, is to try and say, what group of people is that going to occur to? Can we anticipate? Can we cope with? Is there something that we can do to mitigate what this disaster is about to do to this particular group of people? So this is what many of us were doing as scientists when we were trying to determine who should be getting this vaccine first. How should we be protecting those who are the most vulnerable in this? So in social vulnerability, we usually are talking about the inability of people, or it might be the inability of the federal government, inability of societies to stop some of these negative impacts. And we also are interested in what is the susceptibility for these people in terms of these negative outcomes. These are some of the dimensions that make people more socially vulnerable in this country: being poor, race, ethnicity, religion. Think about it. There are religious groups that are persecuted. That religion may make you more vulnerable to being attacked. Your gender, your age, health, language, literacy. We saw this issue of households, for example, either being in a multi-generational household or being in a single parent household. So the composition of a household may make you more vulnerable to certain things occurring. What you're actually probably going to be more interested in are these dimensions of these vulnerabilities. Like, how do they work? Sometimes what you want to know is, what are the belief systems that people have? What are the attitudes that they bring to bear in response to, for example, hearing about being vaccinated? We saw that some people were hesitant to be vaccinated. We saw some people who revisited the immunization arguments of, will this vaccination result in, you know, my child, which is actually going to come up quite a bit starting in June when we have COVID vaccine for the 6-month to 5-year-olds. But people are going to start asking us again whether or not it causes autism. So we want to really understand kind of how these aspects of social vulnerability can be addressed, because it's one of the best ways for us to make sure that we're going to be able to protect people. Now let's talk a little bit about the social determinants of health. Here, when we're talking about the social determinants of health, you know these things from everyday occurrences. So in terms of social determinants of health, this is where we start talking about how we live. We talk about, you know, kind of what the economy is like, the cultures that we live in. And all of those things are important, because when we don't have them, when we have less of them, when we experience the negative side of them, that's what's part of keeping us from being able to take advantage of opportunities in society, of having the capacity to be able to take care of ourselves, to stay healthy, be well. So I'm just going to pick one of these and talk a little bit about it. For example, living and working conditions. Let's take working conditions. One of the things that we learned quite a bit about in COVID is where you work can be a risk factor. Where you work can be very important to whether or not you ever can take advantage of opportunity in society. Your work environment may be one in which you have little to no access to healthcare insurance. I mean, luckily we now have the ACA, so we've been able to do better, but your work environment also may be a risk for disease. Your work environment, for example, may be a place of harassment, of racism. So there are a lot of things in which these determinants, which this gives you a kind of a better sense of it, in which these social determinants often result in an incapacity for you to be able to be all that you can be. So when we think about neighborhood and physical environment, for example, safety in neighborhoods, some neighborhoods are over-policed. Some neighborhoods, it's as simple as, and to me, this is like one of those great stories to write, is that we do not, in many of our community neighborhoods, have the same kind of lighting. We don't have the capacity for crosswalks with particularly, if you're in Santa Monica and you walk out the crosswalk, you'll see them all light up. Come into our communities and what you're going to find is we don't have these things. And these are those little annoyances that end up as data points in which someone was likely to be hit and there's a motor vehicle accident. As a matter of fact, there's brand new data out this year that talks about the increase in motor vehicle accidents. And in LA, we have some very dangerous communities in which we don't have, adequate lighting, et cetera, traffic signs. And this is particularly important as we're, all this construction is going on. So we're seeing more deaths from motor vehicle accidents. So it's the context of these things that really are important when you're starting to talk about how do I describe this health disparity. The other thing to think about in social determinants of health is it isn't about the health that is the biggest issue that we're dealing with. Because as you can see, if we talk about the estimated impact of social determinants of health, it really isn't about health care. It really isn't about our personal biology and genetics. And it is a little bit about the physical environment, but you can see that a big contribution here are these social factors. And, what research has told us, and we've known this now for a while, is that anywhere from 25 to 60% of deaths in the United States really occur as a function of these factors. We can point at, what's missing in terms of healthcare. We can point at whether or not there's bias that's there, but that's kind of down the road. It's like what got you to needing to go into the healthcare system are things that are literally preventable, and they should be preventable.
Dr. Mays, I just wanted to give you a 2-minute warning, please.
I'm good. I'm coming into the landing. So I just want to give you a few examples. So we think about society as being structured like a ladder. So a good society has safety that's at the bottom. So for those that can't have, disabilities, et cetera, we have something for them. And it's very important to know what those policies are and to make sure that those policies are going to cover the most vulnerable people. And then at the top, what you have is this whole notion, as you can see, is that, the rich get richer. So I just, one more thing here. Those rungs that we're talking about in society, they really represent resources. And those resources say whether or not you're going to have a good life or whether or not that life is going to be plagued by, difficulties. And then with these social factors, it's no kidding. Low education is associated with death. Racial segregation, death. Low social support, poverty. So these things, even though they may seem like they're soft, they're actually indicators that we need to address. So I'm going to stop here and thank you very much for the opportunity.
Thank you so much, Dr. Mays. So we'll move right to Dr. Delgado. Thank you. I think, Dr. Delgado, you're muted still. Okay, there we go.
That was not fun talking to myself. Okay, so I'm going to go quickly over what I want to share with you. First of all, it's a joy to be here because, in fact, we've come a long way in what we know about health. So I'm going to start out by telling you a little bit about my lens, and I'm going to start my timer now so that I don't go over. And because I have a lot of information to share, a lot of these slides are backdrop, so you can get copies of the data and the sources later, because a lot of this is contrary to what people say. And it's contrary to the way people, how can I say it, they telegraph what is the truth about health. So my lens, you should know, is, as you know, here we go. I'm at the National Alliance for Hispanic Health. You should know we're nonpartisan. We also don't accept money from tobacco, alcohol, or sugar sweetened beverage companies. And our mission is best health for all. Last year, we funded $12.4 million to 80 organizations around the country. You will see that California actually got less money than Texas. And the reason is that the government funder was directly funding California and said we could not fund in California at that point because they were already getting money from them. At the Alliance, we also have our foundation. On the right, I have policy and regulatory agenda that we're working on. These might be of interest to you for those of you who are working on policy. And then science and policy, you know, we have our Healthy Americas Institute at the USC Keck School of Medicine. And that's basically what my lens is, but also my lens should be something familiar to you. Many of you know about the report of the Secretaries of Force on Black and Minority Health. And I actually worked for that secretary. I was the Special Assistant on Minority Affairs. If you look at page 219 of the coordinating committee, I am listed there. And that is a concern because this book was supposed to be the first of a series of updated volumes. This was released in October of '85. It was never updated. And part of the problem with what was used in that assortment of data, of a collection of data, is that at the time, there was very little data about Asian Pacific Islanders and Hispanics. So as a result, what was used as a measure was excess mortality. Now, if you use excess mortality as a measure, you cannot document the health concerns of Asian Pacific Islanders or Hispanics. At the time, we didn't collect Hispanic mortality data, so people didn't know how long we lived. But the fact is that once we collected, which started in 1989, we started seeing that Hispanics had a very different viewpoint. So everyone has their lens. That's my lens. But as a clinician, I'm a clinical psychologist by training. My role is to help people readjust their lens. And what better way to do that than to write? And that's what all of you do. I myself, I've written 9 books. 3 were chosen best health book by Library Journal for the year they were written. So I know that pictures, people say a picture is worth 1,000 words. And my response said a word can generate 1,000 pictures. So what you do is very important to us. So one of the things I wanted to do was change the conversation in science. All right. So in order to do that, I decided to write an article. So here's my saga about writing the article. Well, first of all, I first applied to JAMA, and that's the Journal of the American Medical Association. And they had interesting comments back. One of them was that they said that one of the problems with my research and the data I was presented was I needed to analyze by a subgroup, avoiding the arbitration and separation of race and ethnicity, the importance of assessing and reported limited English proficiency, blah, blah, blah. These are all things that many of you say. But the fact is that those very same things also apply to Asian Americans, non-Hispanic whites, and non-Hispanic Blacks. No group is a monolith. We are each made up of a combination of people, and we need to appreciate that. Unfortunately, when I tried to go into what was the history of Hispanics, arrival, acquisition, and war, and also the history of Asian Americans, arrival, acquisition, and war, nobody was interested. So I had to then look at what was going on. And I realized that experts are valued over people. So for example, one of the comments I got back was that I had to use Latino. I use Hispanic because it's gender neutral, okay? They wanted me to use Latinx, but Pew has shown that if you ask Hispanics, fewer than 3% or Latin or Latino people, only 3% use Latinx. But it's favored among experts, which is really in many ways an insult to me because I should be called whatever I want to be called. Anyway, going on, we also know, and for Asian Americans, that term was coined in 1968, and as early as 1994, people were casting aside the diverse history of the Asian communities and focusing on the model minority. And I have the reference here of one of the first articles. So I think that we really have to understand that we're going through a change now. So this op-ed piece where we are Black women, stop calling us women of color, really talks to the experience of what is as the discussions different communities are having. This article was written by 2 Black women. One is a former Congresswoman. We also have in science the legacy of reference man, that a lot of what we know is built on what we know about men. So for radiation doses, a lot of that is built on the impact on men. And in 2010, they said, we need a modern reference man. Can you believe that? Well, you can when you realize that the inclusion of women is still a struggle in most of the research that we know. So we talk about inclusion, we've got a long way to go. So what can I tell you about Hispanic health? First of all, we live longer than non-Hispanic whites. Very controversial. People don't want to hear that because all they ever hear is that we don't have health insurance, especially if you live in Texas and Florida and New Mexico, and all sorts of things like that in those states where the Affordable Care Act had no impact because they didn't expand Medicaid. California and New York were wonderful, but many other states where Hispanics live were not. Anyway, the bottom line is we live longer than non-Hispanic whites. The other thing is, we may have more excess weight, but we have less heart disease than non-Hispanic whites. And that's very important because that means that in the science, we have to really rethink what happens to people. This is not a genetic difference because as people adopt the North American lifestyle, they start to lose those good health outcomes. Okay, I'm gonna go really fast. We do have diabetes, we live long and suffer. Pregnancy-related mortality ratios for Hispanics and Asian Pacific Islanders are very good. And when you look at the amount of insurance, you see that Hispanics are the group least likely to be insured regardless of age. But if you look, and people say, well, Hispanic subgroups are also different. Yes, that's true. Here's a good example. By subgroup, sodium intake is different, but the bottom line, it's less than it should be. And the potassium intake is also not what it should be. And it's different by subgroup. If you look at leading causes of death, if you look at non-Hispanic Asians and Hispanics, our major cause is cancer, as opposed to non-Hispanic whites and non-Hispanic Blacks, where it's diseases of the heart. So really, we have to go beyond diversity and need new models of healthcare. I mentioned this article because while JAMA rejected my article for the reasons that I cited earlier, the New England Journal of Medicine published it, and it really makes us rethink what we know. We also have to change when people say they have evidence-based processes, on whom? One of the major problems we have is most of the evidence does not include our communities, whether it's the cancer genome that underrepresents Blacks, Asians, and Hispanics, or whether it's the Genome Type Expression Project, which also represents all the communities, or even the guidelines for the prevention of cervical cancer, which fail to take into account that the issues with Black and Hispanic women. We know that all these genetic, social determinants, and race and ethnicity are key. Some journals are changing. Everyone has to change. The underlying causes of many diseases are unknown. And most important of all, we have to know that understanding is more than numbers. Until we get there, we will be what now someone called us U3, understudied, underrepresented, and underreported. And as a result, we are underserved. Thank you.
Perfect. Thank you so much for your time, Dr. Delgado. And we're going to continue with Dr. Nines Ponce.
Thank you. I'm going to just put something in chat, my email, and let's. interesting, the slideshow feature is not working anymore. It was earlier. So I'm going to start with, hang on, just a few. I'm going to start with the punchline on when data overcomes those 3 U's that Dr. Garcia had said, that Dr. Delgado had said, that it is, you actually then can illuminate a lot of the hidden populations. And in this slide, we see that, so this is 1985, the US Department of Health and Human Services, that's the Secretary Heckler's report that Dr. Delgado talked about. There was very little insights if you look at what researchers use, PubMed, on the Asian American and Native Hawaiian Pacific Islander population, very little research, lots of things that happened. In fact, we mourned the loss of Norm Mineta recently. He was the instigator, the sponsor of the Asian Pacific Islander Health Improvement Act in 1990. So there infrastructure started happening on data disaggregation for the Asian American Pacific Islander population. And it wasn't until around 2001, 2003 that you do see the tsunami effect of articles on Asian and Pacific Islanders, both in the aggregate as well as specific subgroups. The data is not causal here, but the California Health Interview Survey, which is a survey that I run, came on the scene around that time. And we do then see this immense increase in the number of publications. And we do look at the sources, and I'd say about 80% are from the California Health Interview Survey. So I'm sorry, I don't have this slide. I can't seem to do this slide thing. Oh, there it is, okay. So data, as we know, and you as journalists here, data is also about stories. It's not just the quantitative aspects. But there are several sources of data when you go look for it. There's the surveys, which I'll be talking about, but there's also electronic health records, registries for, say, vaccine registries, claims data, how people pay, what's getting paid, what's getting covered, COVID case and death counts, which we've all been monitoring, over the past 2 years, and then also population-based data from the census and the annual survey called the American Community Survey. They have 1-year data files, and they also have 5-year data files. 5-year data files are great to use because then they can get at more of the granularity of race ethnicity from these 5-year files. Then, of course, there's storytelling, there's testimonies, there's lived experience, and that's what you as journalists are uncovering for us in tandem with this data. So this is just also there's spreadsheets. I think during the pandemic, I certainly learned how to use Tableau and use Tableau. Getting at these quick dashboards are really important to get at a view. And it is this last map here. I don't have the full screenshot, but it's something from the Native Hawaiian Pacific Islander Data Policy Lab at the center that I run, starting to look at the COVID case and death rates for the Native Hawaiian Pacific Islander population, and where the cases are highest are the cases where it's a darker color. So I'm a measurement person, and it is key, and measurement is key to achieving health equity. CDC, as was mentioned earlier, the definitions of health disparities and health equity are there, but there's 3 roadways, and I'm on this measurement roadway, and where data practices have to support the advancement of health equity. It is an infrastructure, so having good data is an infrastructure, but data equity, which we're hearing more and more, is where data are collected, analyzed, interpreted, and distributed such that marginalized communities have a say. They have a say in the whole process, in the design, access to, and use of these data. So not just an afterthought, what do you think of this data after, but really being part of, we really think you should talk about experience of, experience of discrimination. We really think you should start talking about wildfires, and so I think that this is really important in terms of what data equity means. So the California Health Interview Survey We had two main objectives when I first started the job 20 years ago and starting the California Health Interview Survey at UCLA. And it was actually first to provide sub-state local estimates. But since I was an advocate, and so while Jane was at Secretary Heckler's office, I was actually one of the advocates complaining, through the Asian Pacific Islander American Health Forum, that the model minority myth just continued to, spread just because of the way that the aggregated data was presented and looking at this excess death mortality. So I was an advocate before I became an academic, and I wanted better data systems. So when I came on to see with CHIS, I really wanted to make sure that it wasn't just about local estimates, but it was about measuring health disparities in the state. And Dr. Mays talked about all the different dimensions of health disparities in the state, race, ethnicity, sexual orientation, gender identity, citizenship, immigration status, documentation status, disability status, educational attainment, occupation, income. And so this is not the universe of all the multi factors and identities that people have that shape the way that they live their lives and shape the way policies are made that affect their lives. So centering equity in population surveys, I have an article in JAMA. So JAMA, I think, has changed a little bit. I'm also going to be an associate editor now for JAMA Health Forum on diversity, equity, and inclusion, so that we do have a lens that is, I think, more accurate about what the communities want. And so centering equity is that we have to have an explicit measurement objective to eliminate health inequities, and we do in CHIS. And then the community co-production, the organizational commitment, and then what I always say, because I'm actually a health economist, is I start off with then quality and efficiency is better. So equity absolutely is the goal, but when you get the measurement right, then you actually have better data. And with better data, then policies then can be targeted and not wasted or not be put, ill-used in different initiatives. How we've impacted data equity, just, well, it's a fabric, right? A survey is a fabric. Are you really showing the fabric of the population you purport to represent? So we have social demographic information. We have Asian and Native Hawaiian Pacific Islander subgroups per OMB recommendations, but also we have about, I think we collect about 20 different subgroups, Latinx subgroups, American Indian, Alaska Native. It's important to get a tribal affiliation. It's also important, not just tribal affiliation, but whether they're federally recognized or whether they're state recognized or not recognized tribe, because it imparts if they have access to Indian health services. SOGI, sexual orientation, gender identity. And in 2021, there was writing categories for the white and the Black African American categories to get at the heterogeneity within populations. And most importantly, that there's been a lot of thought and national, and content tests about the MENA population, the Middle Eastern North African population. We did not add this because we use census as denominators, and the census did not continue with that. So we are using a white and Black African American write-in. We oversample. So once you continue to disaggregate, once you split and split and split, then you've got small samples. And so we oversample. We also conduct a survey every year, so you can pull over several years to increase your sample. We oversample for American Indians, Alaska Natives, for Black and Latinx oversamples in some areas, and we oversample regularly for Koreans and Vietnamese. We conduct a survey not just in English, but also in Spanish and Asian languages of Cantonese, Mandarin, Korean, Vietnamese, and Tagalog. And we recently conducted a survey of adults for two groups with inadequate samples and probability-based surveys, NHPIs and LGBTQ. We have questions on hate, unfair treatment, and the new topics that are coming out this year are on wildfire impact and adverse childhood experiences, firearm access, ownership, and storage. And that'll be like one of the first times we'll have topics on that, on firearm safety. This is something on life during the pandemic. This was special questions on COVID. This is in 2020. We continue to have these in 2021. And so this is just at a glance. This is available at our website, so reporters can just go quickly and looking at, quick views of what's happening. And then for race, ethnicity, and unfair treatment, there was a question on that. And the proportion of Black and Asian adults who reported unfair treatment during the pandemic was much higher than in other groups. And the consequences of this unfair treatment lead to mental health issues. Suicidal thoughts among those who were treated unfairly was higher. Likely serious psychological distress was also higher of those Californians who reported being treated unfairly because of race, ethnicity during the pandemic. So we have also a special Asian and NHPI COVID-19 sample, which we developed with the UCLA Asian American Studies Center and is funded by the state legislature, the API caucus of California. We continue to ask these questions, and this is also a new partnership that we have with UC Riverside with AAPI data. So this is the impact. I think, you hear a lot about the hate incidents, but it's more of registering. Registering. But what about population-based? And so population-based, 6.8% reported directly experiencing a hate incident of Asians and Native Hawaiian Pacific Islanders, but witnessing, it's a quarter of the Asian and NHPI population in California reported witnessing another Asian and Native Hawaiian Pacific Islander person being treated unfairly. And that's a quarter of about 6 million people, about 1.5 million Asians and Native Hawaiian Pacific Islanders actually who had been affected by just witnessing a hate incident.
1 minute, doctor.
Okay, so hate incidents due to COVID, more for women than men. And then this is one of the dashboards where you can get at the ethnic subgroups. This is my end for reporters that, this was a question of where do you get your information sources? And so there's television mainstream, but I note that there's actually 43% of Chinese use social media. And I just looked at the survey that some of you filled out saying none of you look at social media to get information. So it's just a good juxtaposition. Here is the resources, and I'm gonna end there.
Thank you so much, Dr. Ponce. Thank you to all of our panelists. And I just want to add, these three experts have expertise going back decades, looking at health disparities, health inequities. It's become such a hot topic now, and there's a lot of funding. So there's a lot of newly minted, health equity experts out there that have just popped up, discovering racism in 2020. So I just want to encourage anyone to really make sure you're going to true experts that have this long-term expertise and the deep vision that these experts have. So we have a lot of questions from the survey, and we'll be taking them in the chat. But I want to start with, maybe you can start, Dr. Ponce, and then the others. You have so much data, and you have beautiful, dashboards that make it, I think, really easy for journalists to process. But that's not always the case. And, there's so much data, which is a blessing, but I think it's really hard. Not all of us work for places that have data desks, or we're not statisticians. I did a story on this. This is a 20-year-old report on health disparities. Yeah. And you can see it's, and this is 20 years ago. So there's this much data now. What do you say to journalists? Like, how do I get overwhelmed sometimes, charts, numbers, what advice do you have? Do we come to you? Are there, how do we deal with this if we want to do a story?
So I still think that we lead with community. So I think in COVID-19, some of the stories that led us to create better data systems for access came from journalists. So I remember, so I think that part of it is that if you start hearing some of these stories, that you do reach out to us. And I remember, Usha, you spoke with me like really early on. I said, well, I don't know if there is data. Then it actually prompted looking at some more data. So trying to, I went to another one of these, and somebody had mentioned CDC Wonder. I don't know if some of you have used that dashboard. So you get a national picture, but that's also really clunky to use, and I'm a data user and a producer. So what we try to do is in the California Health Interview Survey at the Center for Health Policy Research is like these infographics and these dashboards. And also later on, I'll put some trainings. We have trainings and on-demand videos. I think, yeah, you should come to trusted sources in the community, trusted sources of academics who work with communities and who have, their ear on the ground with communities. But I'm gonna yield to my colleagues because they may have also, some better ideas on how to get these sources of data.
Yeah, I would like to add, it depends what kind of data you're looking at. If you're looking at data for older adults, for example, a lot of people look at Medicare data, but Medicare data is notoriously terrible for providing data by race, ethnicity. So you really, in some areas, the data are not so good, even though people have nice looking dashboards. And the reason for the Medicare data not being so good is a lot of the race ethnicity data are tied back to when people first enrolled in Social Security, which was a long time ago. And then the categories were different. So I think, and then they use sort of algorithms in order to try to estimate what those data would be for older people now. So I think it's, you have to look at what data are you looking for and where is a good source, and it varies greatly.
I'm going to make a suggestion that you really, and Usha, you started this, is that you really cultivate a set of sources, because you can go and get an article, and some of us that really know the community will know that despite that article being published in JAMA, what it is that it doesn't say about the communities and what it is that needs to be said about the communities. One of the things I'm going to share with you right now is that I'm sitting on a National Academy of Medicine committee looking at the census. You're going to have to start worrying about the census, for example. So you're going to need to cultivate those people who can help you to understand. And it'll take a time and then you won't need us. But right now we're trying to figure out how to develop, and I'm keeping community in mind, but how to develop reports, infographics, et cetera, that can be usable, where you don't have to have a 10-year PhD statistician that is sitting with you. But I think the best thing that you can do is, and so this is how we're here, but some of you have sources that really are dependable, and they will work with you around how to interpret what's there. And sometimes what we see, not you, but others put out, some of us are like wanting to tear our hair out because it's like, well, that's not all that there is. So we love that you come to us. We love, it doesn't have to be always just on our own article. I mean, we will help understand science in general. To the extent that you make science valid is the extent that when a disease breaks out, then as credible messengers, we can be helpful. So what you do is so important. So, I would say, and I'm not going to speak for everybody, but, I'm happy sometimes to just talk about what you're thinking about at the beginning of a story and telling you some data to look at.
Yeah, it's the same with me. The best stories are the ones that we can help you at the beginning and maybe give you some sources of where to go. Because in fact, depending what is the point you're trying to make, it's you would go to different communities or different sources to get it. And these are very, very tough times. There are a lot of, I think that Usha called them equity tourists. These people who have never cared about race, ethnic communities, and all of a sudden they're scooping up the dollars and considering themselves expert because they were an expert on, I don't know, on making chocolate. And now they're saying, oh, well, I can do this too because there's money there. So I think that that's a problem. And also be very careful with the data. I love CDC, but when it came to COVID, we had to fight with them, advocate to get data by race, ethnicity, and gender. And now we have the situation. I live in Washington, D.C. My locality is not reporting to CDC code, the COVID cases we have anymore. They just decided to stop. So I think part of it, we're also seeing a mistrust in government. So some of the data sources that we always used to trust, we now have to see, are they getting all the information they need? And are they collecting it by race, ethnicity, and gender? This is not a new thing. At this point in my life, I did not think I'd have to be saying what I said, nearly 40 years ago, that this stuff is important. But more than ever, it is important. And also we have to be realistic and say there are plenty of people who come from diverse communities who go, oh, that's not really important. Race is not really important. Ethnicity is not important. We have to look at the biological factors. One of the slides that I showed that one of the preeminent publications said, you have to look at all of it. And we now have the computer capacity to do so, and we must do so.
Good information, and that's a really good point, Dr. Delgado, to go to our next question. And we're going to talk a little bit about inequities in all aspects, starting by identity. We have seen some of the topics that have been mentioned here about how people identify, like some people don't think people of color, it's a good term. Other people think that, you mentioned earlier, the Latinx term, and also about how non-Hispanic people identify themselves. And the reason why I'm asking this question, it's because somebody mentioned on our survey that because they look Latino, so they are treated as Latino, even though they're English-speaking people, and they just send them to Spanish-speaking places where probably they do not get the adequate help. So what do you think about this, where the inequities start by how they identify themselves?
Well, I think if the person is sent to a Spanish-speaking place, they've upgraded. But it's all a matter of your viewpoint. I think you have to ask people what they like to be called. For example, when I talk, one of the things I'm involved in is the celebration of the 250th anniversary of the United States. I co-chair the Health and Wellness Committee. And this is a big celebration, and bringing in the voices of all the different communities that make up the United States now is challenging because people focus on the 13 colonies and non-Hispanic whites. I said, well, in Texas, you're not a non-Hispanic white, you're an Anglo. So why are you called an Anglo there? And I think you have to ask people what they want to be called. And that is something which people don't like to do because it doesn't fall into discrete categories. But asking is what you do. For me as a clinician, I meet my patient where they're at, not where I'm at, where they're at. And as journalists, that's what you do best. You meet people where they're at, and we have to ask questions. Let them answer, let them tell us.
Just comment, and I'm going to wear my hat as a scientist now. One of the things that increasingly I do in my work is make a distinction between a racial classification and racial identity. Most of what you're using is often how someone has been classified. But if we really are trying to get down to the behavior, changing behavior, trying to have a pathway to prevention, how people identify, how close they are to that racial ethnic group is really more important. I'll give you an example. There was a study that was done in Black women and weight management. Black women who identified as being more aligned with, the Black community lost less weight, but it wasn't bad. It was they had a different image of body. And the women who, race, their racial identity was very low, they had the best outcome. So you can see that a provider not understanding this is going to start to push one group, and the group is like, well, okay, I wanted to lose some weight. I wanted to get a little healthier. So we need to start thinking about in health, where the person is coming from. Dr. Delgado said this so well, you meet them where they are. You create programs where they are. Mm-hmm. And part of just knowing that what a person racial group that they belong to is that's going to get to be yesterday's news in health. We're learning that there are too many subcategories of people, that we don't all eat the same food. We don't have the same susceptibility to, diseases and disorders. So, be on the side of creating a new wave of change, which is meeting people where they are.
And I just want to say that, since we measure race ethnicity in our survey, and among multiracial populations, we do have a follow-up question on, you said you were Black, you said you're Filipino, and you're Latino, you said you're Latino. So do you identify with one, primarily over the other? So it's not coercive. We don't say, which one do you identify with? And if they say, yes, I do, then we ask which one. And so I think that helps in terms of the tabulation of the different categories. I also think that it's your affinity, as Dr. May said, but also it's how people perceive you. I think as Jacqueline, you started to ask, and so there is. I'm thinking about adding a question in the next CHIS on what my colleague Nancy Lopez from University of New Mexico talks about a lot, is about street race. How are you perceived? Because are you stopped by police because of who they think, which group do you belong to? So that how you're perceived is also shapes how people treat you. And on that note, so I get the soundbite in, sorry, Usha, that I really want reporters to start changing the way they use language, is step away from saying vulnerable people or disadvantaged people, or, so it's because it puts the blame or the onus of getting out of that disadvantage on the person, whereas it's the systems and the structures of our society that led to these disparities that Dr. Mays talked about in describing the differences versus disparities. So now it's more about people made that are marginalized, people that are minoritized, and don't say minorities, people are minoritized, people that are made vulnerable, so that it really signals that the situation we're seeing of inequities in the society were, not, poor person, too bad, but really it was because of all the structures that we need to dismantle that have been inequitable for generations.
And I would make a plug that, one of the slides I quickly went over was the one on history, but that's important because the history of each community is key. How you first arrive as an immigrant, undocumented, refugee, documented, if you were already here, like the people in Puerto Rico or in the Southwest say, we didn't cross the border crossed us. I mean, the history of a community is very important. And for example, most Americans don't realize that the Philippines was part of the US until 1943. I mean, so it's like lots of things that people don't realize about our connections to each other. And my whole work is saying, not only do we all belong, but we belong to each other. And that requires a certain level of responsibility to each other.
These are really great points. And I think what we as journalists who care very much about words can take away, and some of this is from the chat, not using people of color. I think Dr. Mays mentioned this means yellow and red, and these are terms we would never use. Not using minorities, which may not even be a true fact, right? As the population of the US becomes non-white, the white are going to become the minority. So it's not even sort of true to use that term. I think what's challenging for us is when you say, people underrepresented in medicine. Editors are, these terms are long and they are, sometimes add a lot of words when you're writing a short story, but I think that is something that we all just have to grapple with and have our language evolve and not use shortcuts. I want to move on to another topic that I think people are finally talking about, which is actually talking about racism within healthcare. I feel like that's something that was always there, but not discussed as openly. And now I'm seeing, studies, people are actually studying, the stress effects of racism. So can any of you speak about that? Is that a trend you've noticed, that we're now discussing this more openly, and that might, benefit and help with the fight against health disparities, and as we continue working on this?
I think that's part of a broader topic. So racism is there. The bottom line with health, it was always a one size fits all. And that was based on that reference non-Hispanic white man. So if you were an older person, if you were LGBTQ, if you were a person if you were a woman, the kind of care you got by the healthcare system was not what was needed for you. So in health, we're only now discovering that people are different, because for a long time, the model that we had was that, we were all going to follow this one model, but it was all based on non-Hispanic white men. So yes, it's racism. So we have that. So people, like in the medical training, when you go in, you're trained in your case study to say, this was a 23-year-old Black man. This was a 24-year-old Hispanic woman. They were saying that stuff before they knew about the differences in healthcare and health outcomes and what our health conditions were. So yes, there's problems with our healthcare system, and it starts at the beginning in the training, through the data collection, throughout it all. So it's not just there, it's just how we see each other has been problematic. And the science that drives us, if you have good access to healthcare, it doesn't matter if they're giving you the wrong medicine or if you're getting the wrong care. So for example, women who would go in with heart problems were diagnosed with depression. And it wasn't until 10 years ago that they realized that heart problems presented differently in women. So there's a whole area of research, of opportunity, and really interesting stories about how racism and every ism you can think of was embedded into our healthcare system.
I'm going to say something about this issue of racism, because, and it's not going to be as popular as maybe you think, but I think we need to do this differently now. What happens when we talk about the big category of racism is we allow people to escape from accountability in some ways. As soon as we say racism, we start talking about huge structures, and it's like everybody throws up their hands. So I'm starting to dial back and try and get specific. I like talking a little bit more about discrimination, because I can talk about who the target of the discrimination is and who the perpetrator of the discrimination is. And I'm starting in my work to study the minds and what have you of perpetrators. How, as a human being, can you treat this other person this way? What can I do to modify your behavior? The other thing that's become important for me is there's so much diversity that when we also do racism, we lose that very diversity. And it's part of what, when we start talking about intersectionality, that's important for us to step back and see. So sometimes I think we're letting people off, and I can tell you that I can give you the scientific evidence for implicit bias. I do not let people say implicit bias in front of me. It's like it doesn't work, because an implicit bias, you're really saying it's unconscious. You use the word microaggressions. You act as if it's a small act. If anything, we should be saying macroaggressions all the time. Do not determine for me whether the word in which you call me was a microaggression. That takes away my experience if I'm the one where the intervention needs to be made. So language has become so important, but for us as scientists, it's important for us to realize a lot of the things that people are saying are implicit. They're not. People are not that unconscious. We've left that era behind. So I think we need to move on. So as a scientist, I'm starting to rethink how I use these terms, because I want to see change. I'm not at documenting and having this, great, upset, but instead I want something such as a perpetrator to be identified, to be treated, to be punished, whatever it needs to be. But using these big terms, I think we may not still be doing ourselves a service.
I think also it's important that everyone here who's listening to us, I want to thank you for being here, but it's the people who aren't here who really need to get much of the message that we're trying to share with you. Because you can write a great story, but your editor or the people above you will change it. I can tell you while JAMA, and I have a good relationship with them because they're one of our members, the AMA is one of our members, even though JAMA is independent. You know, the New England Journal of Medicine went back and forth with me. They wanted me not to use Hispanic, to use Latinx. I showed them the data from Pew, and they said, wow, we didn't know that. I said, yes, ask people. So I think that even in that case where I had been rejected by 9 publications before the New England Journal of Medicine, the most prestigious journal, accepted it, they were willing to change their view. Now, most of your editors will not. So if anything we can do, I'm sure that Dr. Ponce and Dr. Mays would agree, to help you as you move forward to provide you with data, I'm sure we're all happy to do it.
Yeah, and there is a shift in academics of different. There's a lot of so JAMA, I mean the editor-in-chief left or was fired because of the story of because of the story that it actually was more of a social media plug on an article where someone said, well, doctors aren't racist. You know, so I think like how doctors are overwhelmed with dealing. Now we have to, you know, we only have 10 minutes in a managed care setting, and then we have to get the backstory of social determinants of health. And now we have to like, are we on the hook now for dealing with racism? And so, well, doctors, it's like France, like don't collect race, ethnicity. You know, color blindness does not lead to solving the problem. Mm-hmm. And so everybody's sort of at this moment, these journal editors are at this moment. Health Affairs had a special issue on racism. We actually have a paper there that looked at Filipinx. I use Filipinx. We can have a debate that Filipinx AO on colonialism and the interlocking effects of colonialism and racism. Like I think every major journal now has a special issue on racism. So it's top of mind, but as you said, Usha, I mean, there's a lot of health equity tourists out there. And so they don't have the deep knowledge of Dr. Delgado and Dr. Mays. This is actually her area from like when I first met you, Vickie, like what, over 20 years ago, this has been your area. So it's, and then I see my students, like they just put in a regression model, a statistical model, you know, race. And if there's something lights up, then they say, oh, it's racism. So then also people are like rushing to using the word structural racism in abstracts because it's going to get like maybe picked up. But it's at a moment right now where we need more specificity, but I'm actually glad of this moment. Vickie, you may disagree. I'm just glad that this moment has come because it is we wouldn't have this change of the JAMA editor getting fired. We wouldn't have this change of having full issues on racism in the major journals, Health Affairs being the one I heard is on Air Force One, right? So, I mean, so I think it's really something that journalists, yeah, you got to go to your trusted sources to then go through this, but it's, it is what I hope though, and I hope journalists will continue is to cover these stories is that it doesn't go away because my fear is this moment of wokeness is going to go away. So that's my fear. So I think journalists really need to make sure that these stories of inequities continue and what the source is, like not just the current situation, but the whole backstory of how this happened.
Well, but I think it's more than that. I think if you focus on the inequities, that you focus only on the negative side of the equation, that you also have to look at the contributions of the different communities. And in fact, when people talk about racism, it focuses on the experiences of the Black community. And those are real and negative and powerful experiences. But the historical history, the history of Hispanics and Asian and Native Americans is very different. And those need to be looked at from a different lens and understood and valued. And I think that that's part of the problem, that Health Affairs, for example, is a publication that if you look at it and you look at all their publications, very little of it focuses on either Hispanics or Asians, and doesn't even look at the Black community in a way which is healthy and positive. So I think I'm a little tired of everyone using a deficit model when it comes to any of our communities, and not seeing what are the contributions we make. You know, JAMA wouldn't have changed if it weren't for two Black female doctors who raised a ruckus about the podcast that was made. So, so part of it is you have to look at what makes change. And so, and by the way, I submitted my article after that. So it was last July when I was told culture was not, something that I was going off on a tangent on. But it's, so I think that change all is a matter of the reviewer and who sees things. And that's why for the journalist, who reviews your work is very important. Just like who reviews any work we do, the persons who are making the decisions, we have to help to change them. And sometimes we may not do it, but eventually we'll get there. We just have to keep trying. And I think that Vickie, Dr. Mays made a very good point about the concept of racism. And I'm going to think about that. And really, you gotta, it's like, you don't eat an elephant all at once. You gotta bite it wherever you can. And eventually it'll be gone. And I think that, I've been biting, okay, I'm gonna start biting more at the elephant and they'll be gone.
Excellent. Great information. Great information. We're getting close to the end. We have one more question for the three of you as experts. What are some of the stories that you think that we are missing for the health reporters and for the non-health reporters? What are some topics that you would like to hear?
Just really quickly, I put in chat housing. You should cover more on housing.
Perfect. Anything else that you would like to see? Any of you two, doctors?
I'm very biased right now about COVID because it is so detrimental to our communities, but it isn't covering COVID, the disease. If I had my wish list, there are two things. We are about to have our children devastated by COVID. And that's, it's across the races. And it's really important to start talking about their mental health. It's really important to talk about, and I have an article under review right now at the American Journal of Public Health, and it really talks about, we're being so silent about how many kids have lost their caregivers, their grandparents. In the Native American community, they lost elders, which meant they lost their language and what have you. So that, and then, again, I'm gonna be biased, but I really would love to see people do more about mental health, not just mental health disorders, but the lack of services, the inappropriateness of the kinds of services we have. The big stories are you pay for healthcare and you go to your panel and you can't find a mental health provider for like 6 to 8 months. I think you could bring the house down around the lack of what your health insurance provides you right now.
Yeah, I would like to see more stories on artificial intelligence and how it takes into account race, ethnic communities. I'd also like to see more stories on environmental issues and how the nexus with that and health, that is so important. One of the bills that we're supporting and have been trying to get passed is the personal care products bill. Now, why do we care about personal products? Things like powder and, lipstick and shaving cream. It's because lower income people, whether you're Hispanic, Black, Asian, or, whatever, that you are more likely to get products that have chemicals that may have been banned. So we're very concerned about this. So I think the environmental impacts on our communities, not just in products, but also in the workplace, are very good issues that it's not just health, and the impact of all these on us. Also, I would like to say something which is really important. I got really pissed when HHS started talking about, obesity as a major issue, because I thought that would just further stigmatize Black and Hispanic women. And of course, what the data shows, and Stat News covered, is something called the obesity paradox. So that it's not just about, and the obesity paradox is like, gee, being overweight, not obese, but overweight, those people actually live longer than people who are normals. And that for Asian Americans, the whole stuff on obesity is misdirected, because it's like their risk factors are kicking at a different point. So part of it is like, if you frame something using some like obesity, make sure that it's meaningful for different people, or it's meaningful for them. So I think, like, when people want you to cover stuff about obesity, remember Hispanics that, we have always been chubby and stuff like that. We live longer than non-Hispanic whites. We have less heart disease. So hello, what is the real story here? So why are we stigmatizing other women? And if you look at Black women, there's a group of Black women who live to be a very old age, and now they're starting to study, how could that be? So I think part of it is understanding what is the science behind people, and stop telegraphing things like all people who are fat are bad, and this is, and they're using up all our healthcare resources. No, let's give the full story and an accurate one.
A great point. Thank you all so much. It struck me, we asked you to be brief in your introductory remarks, and it struck me that each one of your slides could be a webinar in itself. Asian hate, social determinants of health, but we so appreciate the overview, and that you're open to interacting and being resources for us journalists as we work through these stories, which are not going away. So thank you all. Thanks for attending. And I'd now like to pass the mic to Teresa Watanabe for the closing remarks.
Hi, everyone. Thank you again so much. This has been such an illuminating and provocative discussion.
You are muted. Oh, I think she's frozen.
She's frozen.
Julie, can you pick up? Or someone else?
So we would like to thank all of our
she's back. I think she's
all of
back.
our.
Teresa, you were muted. I mean, you were frozen. So can you say that again?
Oh, okay. Well, I just wanted to thank everybody for this fantastic session. I was saying it's so illuminating, and even as a non-health reporter, I cover education. I just got so many different ideas for how I can apply what I've heard today in my beat coverage area. So I just want to thank the speakers, our wonderful moderators, our co-sponsor, CCNMA, Latino Journalists of California, of course, the California Endowment for the support that made this program possible, and of course, our incomparable chat hosts, Geeta and Anne, both on AAJA-LA's board of director or board members. We will be rolling out other programs on.
So I think she was saying we have several other programs planned this year. Of course, the AAJA National Convention is in LA, so you are all invited.
Inequity.
We would love to see you there.
So stay tuned for that.
Teresa, can you say that again? Sorry, you were frozen again.
You know what, Julie, why don't you just finish it up, because I seem to be freezing up.
Okay, sounds good. So as I was saying, the convention is in July 27th to 30th. We'd love to see you there. We also have several other events. For instance, we have our mental health awareness event that we are planning for June, along with NABJ-LA. And We have our Trivia Bowl in October. So please, if you want to be added to our listserv, please go ahead and drop an email or a message to me in the chat. And CCNMA, Latino Journalists of California, I think also has a couple of events coming up. Lori, would you like to mention those?
Sure, we have a couple other health forums that we're planning. One will be in Spanish that Jacqueline is planning, and that's coming up. And then we're also celebrating our 50th anniversary, and that there'll be a big celebration in November. So very cool. But what a great panel. I learned so much.
Thanks to our attendees as well for your engagement and your great questions. We'll follow up with an email with all the resources, the PowerPoints, links to some of the other slides, and any other resources that we can collect from our panelists and our speakers. Thanks again for joining us this morning. I hope you have a great weekend, and yeah, stay in touch. Hope to see you soon.
Thank you. Thank you for hosting us.
Thank you all.